Good afternoon. My name is Richard Stubbs, and I am the Chief Executive of the Yorkshire and Humber Academic Health Science Network and also the Vice Chair of the AHSN Network. And on behalf of the AHSN Network, it's my absolute pleasure to welcome you to this 30-minute session. We're going to be talking about LGBT health inequalities and also where innovation can help. I'm delighted to be joined by 5 excellent speakers for this next 30 minutes. My colleagues in other AHSNs across the country, Michael Goodeve and Vanessa Hamer, will be talking to us very shortly about some of the work they've led on around our LGBT health inequality and innovation call to action. We're also going to hear from Lawrence Webb from the LGBT Foundation, who's been a fantastic partner of ours during this work. And then also Meg Lightheart and Philippa James from the Indigo Gender Service will be giving us their insights as both service leaders and clinicians delivering real services out there in the community. But before we get on to our speakers today, I just wanted to remind people of the work we've led on at the AHSN Network over the last 18 months. We have done a series of pieces of work which really started to demonstrate our business case for why diversity within innovation is so important. And as part of that work, we undertook to commit to a series of diversity pledges over the last 18 months, pledges that incorporated ourselves as organisations, how we led and managed our staff, and perhaps most importantly, our work as innovation facilitators, and how that work can have such an impactful approach to diversity and health inequalities in our population and with our patients. We continue to embed and to lead our pledges in all 15 AHSNs across the country. And actually, we'll be bringing out a report in early 2022, which will talk through some of the impacts and successes we've had since we've embedded our pledges as part of our work as boards and as AHSNs. If you do want to know more about our pledges, please do visit our website at the ahsnnetwork.com/diversity to see the pledges in more detail. But as well as having our pledges, we've also looked to see how we can have other impact in this work. Hopefully, many people on the webinar today will have already seen our first diversity report, which was published in September 2019. As I mentioned earlier, it really set out the business case for increasing diversity within innovation, and it was also a celebration of our Black, Asian and minority ethnic healthcare innovators. It's still available on the web, and I would still encourage you, if you haven't seen it already, please do take a look. But we haven't stopped there, and since there, we've absolutely been thinking about the other aspects and other protected characteristics that we as an AHSN network believe we have a leadership role to play in helping to promote innovation that supports the reduction of health inequalities for those protected characteristics, but also championing some of the fantastic innovations and innovators who are already working in this space. And to talk to us a little bit more about our current work around LGBT health inequalities, I'm delighted to welcome Michael and Vanessa. Good afternoon, both.
Thanks very much, Richard. Hi, everyone. I'm Michael from Wessex AHSN, and I lead the communications team there. This is my colleague, Vanessa. She also works for West of England AHSN, and she also leads the communications for that. So we're just going to talk a little bit more about our specific LGBT work, building on the work that Richard has already mentioned to you. So we were aware that, like many of us, that as the pandemic was unfolding, that health inequalities were becoming more acute, and it was highlighting where inequalities are. And we decided that the next community that we really wanted to work with and to look at was the LGBT community. However, we were very aware as a network that we don't know what we don't know. So we are very well connected to the NHS, academic partners, and to innovators, but we were not especially well connected towards the LGBT community. So we felt it was really important as a starting point to work with the LGBT Foundation, to use their expertise, also because we were aware of their initial reports that looks at health inequalities for LGBT people. And they'd actually also published one during the pandemic, which was proving that LGBT health inequalities were more felt during the pandemic. So we decided that the best thing to do would be to do a review of evidence. So what's out there, what do we know about health inequalities? But then I think probably from the HSN side, at least, with a gut instinct, we knew that there was inequality across the board. But what this evidence review did was help us actually get it all onto paper and outline all of the different health issues that we could pull together and we could really work from. And then what we wanted to do from that was to do a call out to the system. So again, using both the power of the AHSN network and all of our connections and the LGBT Foundation, see what's out there, what great work is already happening, both from an innovation side, from within the system and from the community. And I'm now just going to pass over to Vanessa, who's going to talk about what we found.
Thank you, Michael. So the evidence review was really comprehensive and building on the great work that LGBT Foundation had led with in the two Hidden Figures reports. You can see from the list on the screen, it's incredibly wide-ranging list of issues that the LGBT community face around accessing healthcare and the kind of service provision that they receive. I mean, from lesbian women facing unconscious bias and the assumptions they face when they're accessing fertility services, to lack of health services for transgender people, through to increased likelihood of drug and alcohol use. It's an incredibly broad spectrum that I think we were hoping our innovation call would find examples of good practice, best practice out there that could tackle some of these issues. I think personally, when I was looking at the evidence review, when we'd pulled it together, what really struck me, as well as the range of the issues, was some of the stories that were captured in there in terms of the stats and the data. There were lots of quotes as well from the evidence, stories of people. And what dawned on me really was the fact that behind every statistic there is a real person. And it really struck home with me at the time because for the last couple of years, my son and I have been going on a bit of a journey in terms of our experience of accessing healthcare. My 16-year-old son is transgender, and he has been teaching me a massive amount about the transgender community, young trans people in particular, and the accessibility issues, the misgendering, all kinds of issues that I was totally unaware of a few years ago. And it just really brought home to me, I think, this evidence review, that this is something that we have to really push to the surface, is the reality of these situations for so many people, and bring to the fore that these are individuals' stories in every element of the data that we're reading. And how important that has to be for developing innovation as well. So it's not just, what are the issues and helping to make them feel real, but also how do we tackle those inequalities, and how do you drive innovation? And there's been so many studies that show the business case for increased innovation comes from increased diversity. And so that to me has been made very real by this piece of work. Anyway, so that's just kind of a personal anecdote. And I think, Michael, as well, for you, a lot of this work that we've been involved in, there's been a personal driver for you as well, hasn't there?
Yeah, absolutely, Vanessa. And I think touching on the lessons that we've learned as well through this is a really important aspect of this work. I think in our minds, we were going to uncover lots of fabulous innovation that's already happening, and then we'd be able to use our collective powers to show the NHS, look, this is what could be done, why aren't you doing it too? However, I think what we found is that we've had some brilliant submissions in for the work already, and we're starting to go back to those people now and to work out how we can help tell the world about their innovations. However, in conversations with the LGBT Foundation and with Lawrence, who has a much closer understanding and relationship to the community, it was also becoming evident that we still weren't managing to reach people. We weren't necessarily managing to reach some projects that had come from the community up. And that for me was a real learning point. I sort of assumed that being a member of the community myself, being a gay man, that those would be enough credentials to get me through this work. And actually, it's been, again, a huge learning process for us. And I think on that note, that takes us nicely over to Lawrence, who's going to tell us more about community-based innovations.
Hello, everybody. My name is Lawrence Webb, and I am Deputy Director of Inclusion at LGBT Foundation. LGBT Foundation was an organisation established in 1975, and since then we've been working really hard to create a safe and equal society for all lesbian, gay, bi and trans people to be able to achieve their full potential. So every year we serve around 40,000 LGBT people through our services. We amplify LGBT communities' voices, we provide support, and we offer hope to all LGBT communities and our supporters. I'm really pleased to be here today and to take part in this conversation, and looking forward to hearing from more of our fantastic panel.
Lawrence, thank you very much, and it's a pleasure to have you here. Now, I'd just like to introduce our final two speakers for the session, and I will ask them to introduce themselves. So Meg, would you like to say hello to the audience, please?
Hi, I'm Meg Lightheart, pronouns she, her. I'm the service manager for Indigo Gender Service, which is a new NHS pilot for trans healthcare in Greater Manchester.
Good afternoon, Meg. And Philippa?
Hi, my name's Philippa James. My pronouns are she and her, and I am one of the clinicians at Indigo Gender Service. I work as a GP in inner city Manchester and have been part of the development of Indigo Gender Service over the last 3 to 4 years.
Thank you both. It's a pleasure to have you here. Meg, starting with you, Indigo Gender Service is trans-led. What have been the benefits and the challenges of having people from that community lead the service?
Indigo has been worked on for years. So the work that we're doing has come from the co-production between the people who were exploring setting up the project, and then also and the trans and non-binary community. Some of that work was also led by Lawrence. The success of our service has really come right from the beginning of working not just in consultation but in co-production with the community and being accountable to the community. What that's also meant is that we are trans-led, both by that community, by having me in the post of service manager. We have a team of care navigators whose job it is to guide service users through the service and make sure they have a named contact. All of those people are trans and non-binary, and lots of other of the roles in the service are also staffed by trans and non-binary people. And there's something about, I think, in the culture of any service in the NHS or outside of it, where if people aren't from that community, we can come in and think that we know both what the oppressions that people live with, but also the ways that services can be designed to improve the lives of marginalised people. But when you actually have people in the service, leading the service, running the day-to-day nitty-gritty of how the service runs, it changes the feel of the service, the processes that are made, the strategic decisions that are made. Everything on all different levels are guided by the fact that trans and non-binary people know most about what trans and non-binary people need in terms of healthcare, and knowing the people on the service who are trans and non-binary, they've really pushed for equality and equity in lots of different ways that maybe couldn't have been predicted by people who aren't from a marginalised group.
Yeah, really interesting. And Philippa, as a GP, I mean, are there any particular innovations and ways of working that have supported your role with Indigo?
Yes, I definitely echo what Meg has said about the benefits of having people with lived experience working in and fundamental to the service. It makes such a big difference. And so people will maybe confide in a care navigator, something that they wouldn't necessarily tell me. And that works very well because then it doesn't get swept under the carpet. We can address things and move forward. The other things that we've done that I'm really proud of in terms of the way we've set up Indigo is I really feel that we've got the communications right. So we have a GIC, a secondary care clinic, who work as our sort of governance and support, and so we've got really good communication teamwork between us and them, using Microsoft Teams through the days when we're doing consults, and that's working amazingly well, and I think they're learning a bit from us as GPs too. We have got, and we're developing, good network and communications with other GPs, and we are, I think, able to do that because we're GPs ourselves. So we're also very active in the training network. So we actively train in at least 3 of the areas for trainee GPs at the moment as well, and that's going brilliantly well. We have got really good communications between Indigo and the service users and that co-production, and also with all of the other people who work within Indigo, so the speech and language therapists, the counsellors, the psychologists. That's all going extremely well, and we're able to have open and honest communications. We've really worked on being approachable, so we have an advice line which we will talk to GPs within 24, 48 hours of any questions or discussions. I think the other things that we've done really well and that I've really enjoyed is that we've really drawn on the expertise of LGBT Foundation, and that gives us a different way of thinking about things. So there seems to be, I think when you've been in the NHS long enough, almost an NHS think, a way that we always think and consider stuff. And it is so refreshing to talk and to be able to see things from a different view and make things work. It's a lot of fun. And I don't say that very often about my work.
Thanks, Philippa. That's brilliant. And just coming back to you, Lawrence, and actually Michael and Vanessa as well. I mean, so the LGBT Foundation obviously been great partners with the HSN network through this call to action, but I think it's been a journey, I think safe to say, in terms of where we thought we were, what we thought we were doing when we put a call to action out compared to where we've got to. I just wondered if you wanted to just reflect on that and how our own understanding, I guess, of where we are as a society, as a service, in terms of our approach to LGBT innovation is at, and perhaps how it's changed our viewpoint of what needs to happen next.
Thank you. Yeah, I mean, it's been fantastic to be part of this project, because, I mean, one of the things I always reflect on in this space is that I've been working with, LGBT communities basically my entire adult life. And actually, as an absolute keener, was volunteering and doing stuff as a young person before that as well. And I still learn new things about LGBT communities every day, right? So there's something for me about really not being scared of the fact that there is always going to be more to know about communities than you can learn. I'm really kind of seeing that as, thinking about innovation in that context, seeing that as a feature and not as a bug. Actually, that communities are alive and communities are always changing, and communities are fantastic at solving their own problems. But and sometimes where I think communities and kind of service providers can miss each other is in not necessarily understanding that. Because service providers love to fix problems, right? That comes from such a positive space. It's a really good intention behind that, but then sometimes that can translate into this ideology of kind of doing to or doing for, rather than actually listening to and learning from communities. So I think probably for me, the biggest thing that I've taken away from this project, this kind of partnership project with AHSN, also actually from my involvement in the early stages of the Indigo Gender Service project, where really, you know, what I was doing then was bringing together trans communities and GPs to just talk to each other and say, okay, you know, how can we look at all of the problems that you're all facing in the round and come up with a response that does justice to all of that. Really, for me, it's about staying humble, and it's about being open to looking at a problem in a different way from somebody else's perspective. I don't know about your thoughts on that, Michael and Vanessa.
Yeah, I think I would echo some of that, but from a slightly different angle, which is we started the project out with, as you say, all good intentions. You know, the HSN network, we're quite fortunate that, you know, much of our work is very positive. We seek innovations out, whether that's a pathway, a bit of med tech, or an idea to try and help solve a problem, to try and help speed things up for patients, to improve patient care, to try and make things better for people working in the NHS every day. The space we work in is pretty positive, really. And, you know, even through the pandemic, a lot of our work was to help as much as we possibly could the front line dealing with COVID. So I think the intention behind the call out was, as you say, it was very well intentioned. We knew that health inequalities were more acute for LGBT folk. We really wanted to use our powers and your powers together. And, you know, together we had the power of Grayskull, I guess, that we would be able to kind of crack this problem. But as you know, like I said before, we had some fantastic submissions that came in. But then I think in conversations with you, it was also clear that we had missed some of the stuff, some great work that happened through necessity from the community itself. Where, as you say, were we even in our work, and this is what I meant earlier when I said about my gay credentials, well, actually, have I fallen into that trap of biases as well? Have I not been intersectional in my thinking? Have I just assumed that we'd be able to solve it with this call out and by using you guys? Had I really thought about it in the round? So I know that's a little bit of a muddled answer, but I think it's definitely, it goes back to what you said really, which is you have to come into these things prepared to learn and not assuming you know everything. And I think as a network, we knew that on the outset, which is why we partnered with you guys. But also on the other hand, the more we got into it, the more I realized that there's, through biases and through, you know, good intention, you can inadvertently play a part into that overall kind of systemic bias, I guess. You know, at no point would we want to try and disregard things that have come up from the community at all. But did we do that unintentionally? So that's been, I guess that's been one of my big learnings. Vanessa?
I think I'd echo a lot of that. I think that not knowing what, you know, you don't know what you don't know was our starting point. And that's why we partnered with the LGBT Foundation as well. You know, we know innovators. We don't necessarily have those links in to the LGBT community, but we knew there were health inequalities that needed tackling. So the idea of coming together was a great one. And I think the way we approached it was quite brave as well, by just saying that we don't know what we're looking for. We don't know what the answers to these questions are. But what we need to do is kind of push that door and see where it leads. And so I'm not kind of disappointed with where we've got to on our journey. I'm really excited by these next steps, because I think where we've got to is that we've discovered this space where there is so much energy and passion, I think, across the kind of the innovator sphere, in terms of there's a lot of great innovation happening, and within the community itself, in terms of understanding the need and developing kind of responses to that. I think the HSN Network's in a really great space with the LGBT Foundation now for kind of brokering some amazing relationships, so that we can kind of really keep pushing that co-production side of things. So I think that's what's going to make the difference. So yeah, we're aware of some great research through our core, some great innovation. And I think that kind of key ingredient in that we have now is kind of linking everything together, but also asking some really tough questions as well about how this work needs to be prioritized, how it needs to be funded, kind of what happens next from a kind of systemic infrastructure perspective. because so much of this work has had to happen from the ground up, or an innovator's had a great idea for how to evolve a product for a different audience, where actually it needs to be the system calling for this work, and it seems to be kind of the other way around. And I think that's kind of the next step for us together now, is to kind of shove that door open a little bit further.
Thanks, Vanessa and Michael and Lawrence. I think it's particularly exciting to think about what the next steps would look like, and the journey that you've been on, I think, will only enrich those steps. So it's exciting to think about what's going to come out as a result of that. Meg, Philippa, I mean, just a couple of final questions, but one of the reasons why the AHSN network exists is to support spread. And obviously you're championing the service that's very much rooted in the northwest of England. Do you have any sense of how a service like Indigo could and should spread to the rest of the country? I mean, we often find in the AHSN network that some of the conditions, such as clinical champions and really passionate and energetic innovators, are hard to replicate, but are crucial to why services can migrate from one part of the country to the other. Are there any plans to do that? And if not, do you have any sense of what the secret would be to spread?
Well, we just were meeting with the commissioners and us, and after 6 months this morning, and the whole idea with Indigo always was that we would potentially become the template for the national standard of care for trans people, trans and non-binary people in the UK. And one of the things that I think has been a great kind of surprise, but not a surprise, is how many so when we were hiring for the Care Navigator role, for example, we had a huge number of applications that came through for people who wanted to work for trans people who wanted to work for the service. And partially that was through anticipation of the service, partially that was through having hired a trans person who has networks and has some trust in terms of people who would spread that word. And we ended up interviewing 25 people for 6 roles, which was a huge number for us after shortlisting over 100 people. And I think if we think about this rolling out, there's also the fact that there are these communities in cities and towns across the UK, across England, and that tapping into what those communities are telling us. When you were to listen to trans people, what some of the things that people wanted was local care, not having to travel, making it more based in primary care, being led by trans people, having a named contact, having the movement through the system be faster and also less of a template. And that's what we've ended up with Indigo, and that just came from years of co-production, but at its finest level, it was listening to what trans and non-binary people knew they needed and then implementing it. We've definitely got the support of the commissioners who were part of that process right from the beginning, and I think that's been a huge part of our success as well, is how supportive the commissioners have been of making this pilot a successful pilot, helping us to solve issues that come up, so that when we do get towards the end of the pilot, then potentially we can be recommissioned, but also move it into other communities too.
Thank you, Megan. Philippa, just quickly, as a clinician, I mean, how would you encourage other clinical colleagues across the country to adopt a service such as this?
I think the key is ownership of the service, and I think having it in primary care has felt right, because I can easily speak for other GPs throughout the country and how frustrated they are with the lack of transgender services at the present time, and taking control of that and using and playing to our strengths in primary care. We're good at turning things around, at making things work. And I think the more we can sell that to other GPs and show them that it can work, that we can make things better, not just for our patients, but for ourselves as well, is great.
Thank you, Philippa. Right, one final word from each of our panelists. So we're looking for very, very short 5-second answers. But if there was one thing that people should do differently, could do differently as a result of watching this webinar, what would you suggest it was? Michael, I'm going to come to you first.
Approach everything with an open mind and be prepared to learn.
Thank you. Lawrence?
It would be about not seeing health inequalities as a problem, but actually looking to what communities can do as an asset, as a learning resource.
Thank you. Vanessa?
I think be curious, don't be afraid to ask questions, and please try to avoid misgendering people. It hurts.
Thank you. Philippa?
Probably to have and to work for truly functional multidisciplinary teams, and putting service users at the centre of decision making. And
Meg, last word to you.
I would say this, but put marginalised people in charge of their own healthcare.
Yeah. Thank you. Thank you, everyone. Thank you, Michael. Thanks, Lawrence, Vanessa, Philippa, and Meg. It's been a very rapid 30 minutes, but hopefully it's given viewers an insight into the work that we're doing here. Thank you to the LGBT Foundation. Thank you to Indigo Gender Service. If you do want to look up any more information about anything you've heard today, then you can visit the websites, and there are various websites to visit. We have indigogenderservice.uk, the lgbt.foundation, and of course the ahsnnetwork.com/LGBT. As we've said before, please look out for some more of our publications on this work, which will be coming out in the near future in autumn of 2021. Please do enjoy the rest of the conference, and we'll see you very soon. Goodbye.